Hi, everybody. Welcome to the Blockheads 5th edition. We're going to start here in a second with not really a presentation, but just kind of an outline of what we're going to talk about. Today's session is focusing on gaining traction and kind of the how-to of getting from idea to actual implementation. I figured the way that we would structure this is kind of like, what are the barriers? Who is creating those barriers? Why are they creating the barriers? How did you get through them? What do you wish you knew? What is the role of written policies and what is the role of training? So just going to kind of open the floor at this point to whoever wants to talk more about their personal experiences, specifically what are some of the barriers you've run into as you've implemented a block program at your facility?
Oh, I can speak from, hey guys, this is Jonathan Burr, by the way. So I can speak to some of the difficulties that I've had, that we've had at Vanderbilt. I think, first and foremost, one of the issues that we've had is with orthopedics. So a lot of times ortho trauma with a lot of our fractures, they're very hesitant to allow a block in the first place. I think at our, at our main site, that tends to be the case. At our regional sites, where ortho's not in-house, they're not coming, they don't have a resident coming in to see the patient that night. They're going to see him in the morning, like we're admitting our hip fractures. They're a lot more conducive to allowing us pursuing blocks in the emergency room. Sorry for the ambulance, I'm currently driving, but they're a lot more conducive to allowing us to do blocks at those sites and doing just different reductions with blocks and such like that. Regional anesthesia has been has been pretty supportive. They do, there has been a lot of debate on with different various complications, who's going to follow that up on admitted patients or who's going to follow up the patients in general. So they've been hesitant to pursue things like catheters in the emergency department. And they also have a 24/7 APS service. But I would say probably the biggest barrier we've had is with ortho trauma at our main academic site. And then the concern would be if we do, if we do faster blocks, that the orthopedic residents, by the time they would see the patient, they would have lost their exam. That's kind of the most common reasoning for them giving pushback on it. But I think, as we started to do more and more, as we've started to show them that, hey, this is a really good thing. It's supported in evidence. Some blocks even have, morbidity, mortality benefits. They've actually become a lot more apt to allowing it. And trauma is pretty much fully on board. So that's pretty much us.
Awesome. I really appreciate that. I've heard similar things from my ortho residents about losing the exam. But at some point we just have to say, like, well, who's more important, like the resident's exam or the patient's pain level? But that's not a surgeon.
And I think that this is what Jonathan's saying is kind of echoed all around the country. At least when I hear it, whenever we travel, we actually heard this at Astra a bunch. And I think it really stems from taking the conversation away from the bedside. I say this, this conversation has to happen with a bunch of docs, with a bunch of coffee in a room, sitting around talking and looking at the evidence. I think when these conversations happen at the bedside, then it becomes anecdotal bias. And it also becomes not directed at the patient, but directed at egos. So building protocols up front, which we just finished 2 protocols that we're going to hopefully publish, but having that protocol written in stone, because anybody with a hip fracture, I know, ortho knows that a simple sensory and motor exam is probably all you need. Their orthopedic surgeons aren't doing detailed neuro exams unless they're suddenly a neurologist with a bow tie. So I think having a standard that you measure flexion at this point, you measure sensations at this point, document it, and then do the block, which I think is, again, the onus is on us. As long as that's done beforehand, again, it's easier to say coming from a place like my institution, we've been doing this for a long time. I know it's harder. Trust me, I know it's harder at other institutions, but I think the game plan has to be chair, ultrasound director, other chair in a meeting being like, let's do what's great for the patient and then see if that happens. If your chair is some, 80-year-old dude who's just going to fight you, then I think you're stuck till he dies. But I think that in most centers, I think you're getting a new breed of orthopedic surgeons coming on board, and they're all for this.
So I've worked at a couple different spots over the past couple of years. This is Joe Brown, by the way. And it's been interesting because I've seen the protocols or like pathways functionally work both for me and against me. So at one of them in the mother, like sort of the main academic institution, our pathway basically auto consulted APS. So that then it was interesting because we also covered a lot of the community sites, and community sites, they wanted us to teach all of the regional docs how to do blocks. But it was hard because all of the graduating residents weren't doing them in our department. But on the flip, now I'm at University of Colorado, and the way our pathways is functionally written is just either consult APS, or if the ER doc feels comfortable doing it, we can do it ourselves. So I've found that to be very helpful. And the big thing I did to get around for the ortho issue was at the very beginning when I started, I just sat down with them and was like, what is the exact exam that you want documented, so I could build it into the sort of the procedure note. Because the big thing that they got really hung up on for whatever reason was sensation of the lateral thigh, which I have no idea why that matters, but for, from our end, that was the one thing that they were getting really hung up on. So it's helped a ton to have that in and built into the procedure note now.
That's exactly right, Joe. I think that's exactly right. That sit down, what do you want? We will do. And then on top of it, the model that you described as the Kaiser model that we enacted like 8 years ago at Kaiser Northern California, one of our residents went there, and it's the make the call, or if you want to come down and do the block, great. But if you can't do the block, then we'll do it. And then what happens over time, it's like asking your cardiologist to do echoes. They just like they'll just like they trust you after a little while. Just it's that interim period where they may come down once every 5 times, and then after a year or two, they never come down unless they're bored and want to come down, but that's rare.
Yeah, that's kind of the phase that we're in right now is we're establishing those protocols with APS, and we're it is really nice that they're so collaborative. So we've been establishing those protocols, kind of the Kaiser model, and I've noticed already that they've started to kind of come down to the ED less and less.
Yeah, I mean, I think the one thing I've seen, and
Joe.
it kind of goes to the WHO that's coming up next, is the one challenge I do find with having that sort of collaborative approach is for the older docs that don't want to do them, that are ER physicians. It makes it very easy when you can just consult APS, and so it is like basically every time we do any sort of in-servicing or teaching, there's a lot of like, well, I can just page them and they'll do it quicker and I can go see 2 more people, which
but that's fine, Joe. I think that's fine. I think that's actually beneficial to the patient. And
100%.
I think it's great. Like if you want to be a very mediocre doc at a very big academic institution and get you want to change your practice, go for it. I'm not going to fuck the patient over because of your lack of desire to treat patients. So I like that actually. So I think that helps. Hey, Graham, you're at a community shop. Graham was one of my old fellows. I'm curious how the integration of this has happened at your community. Is it even an issue?
That's what I was gonna chime in actually, because I have a little bit different situation. We don't have a block service or anything. It's all kind of, we're building it from the ground up, I guess, so to speak. We don't have residents where I work now. So it's not an issue in that like there's no orthopedic pushback at all. Like we can literally do whatever we'd like to their patients. They just want them admitted and to not be called overnight. But I think having those policies in place would be really good because we can kind of work off of them. And so if there ever was an issue, later on, we could say, well, we have this departmental policy in place, and this is the exam that was documented, and this is how the doc was documented, and we use these standard medications or standard approach that was previously approved. And I think that makes sense because we're not always calling them about acute needs for those orthopedic patients. When you guys are developing these policies, are you developing them de novo, or do you share these policies, or like how does that collaborative work?
We just finished ours, and I like to hear Joe's, but we've always just had this unwritten statement that blocks work at Highland, as you know. So I kind of codified it and I sent it to the chair of orthopedics. He read it and was super stoked. He's like, "This is great. I didn't know. I thought we always just did this. We didn't have it, codified." So then it went to our new chair, essentially signed, and now we have a working document both for trauma, for rib fractures, and for hip fractures. We're finishing up the bimal, trimal fractures, and we're breaking it up in that kind of ED thought process where it's not femoral nerve block, but it's hip fractures get either an infrainguinal fascia iliaca or a PANG based on if it's if it affects the rami or not, and then distal again, so it's very, very clear and linear. And it seems like Dan put something up in the chat.
Yeah, maybe you posted a library for some of those resources.
Yeah, so I'm trying to put together a Google spreadsheet of just everyone's policies that they've gotten fully to the end process to fruition, and then just making them available for everybody.
That's awesome.
Yeah, so we're working on it. It anyone who can contribute to it would be greatly appreciated. And then as Arun gets these things published, I'll add those.
I can toss mine in.
Awesome.
I would say ours are like a sit down at a table, and like literally our emergency department is very heavily pathway driven, sort of similar to the Kaiser model. So there's everything from like syncope to TIA to different grade, like the different MBIG grades of bleeds. And so one of them specifically right now, what we have is just a geriatric hip fracture pathway. And so it's very specific and delineated, has order sets linked to it and the whole thing. So we're not too far behind. I mean, my sort of next 2 years are going to be expanding out of just geriatrics, so beyond 65 and older, a rib fracture pathway that we already have in place, but is sort of nebulous right now, that just says like after attempted pain control, get an FVC. So the plan is going to be to actually add this in there more explicitly so that then, we can feel more sort of supported by the department to do the blocks. And then at the very top of each one of them, all of the stakeholders that are involved with development are signed on. So like the chair of orthopedics, the chair of the emergency department, we have sort of a pathways committee. And so there's usually somebody from that committee that's in there. I will say that what I've experienced so far is APS at our shop is very much don't touch, like if you guys do a block, we don't want anything to do with them upstairs, but they don't really care what we do downstairs. So it's kind of great. I've tried to work on collaborating with them to have a little bit better interplay, but it's kind of left it open to if you feel comfortable doing X, Y, or Z block, go for it. Which I think keeps the door open nicely for us in the department as we continue to expand it out more.
And if you think about this, Joe, I'm sorry to butt in, but if like maybe 4 or 5 centers that have block protocols just looked at their data collectively as a group of block protocol, like literally, I mean, this is the study, right? Like we look at 5 sites that have codified protocols with orthopedics and look at the number of blocks they get versus 5 sites that don't. Look at the sites, look at the blocks they get, and just look at the pain reduction. And I know it's a tough study. This is a very multi-center study, but even if we didn't get the pain reduction, just looked at the number of blocks, you could really demonstrate the utility of this. And this is, I think, the reason why all the big block studies that have come out recently don't have a lot of endpoint data. That's great. There's some fuzzy data in there. It's because they're looking at it too late. They're looking at these people when they get in to the hospital, get stabilized 8 hours later, 10 hours later, regional anesthesia puts a block in. I think if we look at this upfront, I think we will probably have a little more signal. So I think that once we get a few centers that are doing this, I think we'll actually be able to look at places that are protocolized and non-protocolized.
Yeah, I mean, I'll say, I mean, even just we're basically going to redo that study that came out of University of Colorado a couple of years ago. And the signal is, it's not great, but it's massively improved from where we were even 3 years ago, just with a couple extra measures. So even internally, I think we're seeing a much better uptick.
I'm going to stop the screen share real quick just because it's not really adding anything. Have you guys really found that the policy and protocol creation has like mended relationships or been a pathway through some of the barriers on like the relational aspect of some of this?
I'm kind of specifically curious about how you guys have handled that issue about following up with patients up on the floor, complications, and if like developing those policies was something that you guys built into that.
That's a great question.
Kind of loose scale, Graham. Like we basically made it so that our policies to do a 24 to 72 hour callback, which actually is kind of nice when you have residents. Really, it's kind of good for them to kind of get an idea of like how long the block lasts, you know, where these patients end up. And I think you get some wins too, like maybe some of these reductions where they end up being like non-op. I think that kind of like reinforces the idea of doing some of these blocks. And then everything else, we were just doing chart review.
Yeah, so I hate to add more work to people. So I think it's a great idea, Rob. I know that my residents would revolt. So how we've done it is, again, this is the inpatient blocks. If there's any complications, they inform the inpatient team that gets a hold of us because we have the documented note of who did the block. So it goes back to the primary provider that did the block, which we haven't had any outcomes. The discharge one, I'm putting together a new discharge instruction set that gets printed out when somebody does a block that has a clear number they can call back. And again, the only block I'm going to pick with the femoral stuff. This would be we do a peng block and discharge someone with the rami fracture. Theoretically, that would be somebody that would call back and say, we just had a transgluteal sciatic nerve block that a patient came in with a foot drop 24 hours later, and the resident didn't inform them. And I think these protocols, the benefit of these protocols is not for anesthesia or orthopedics, but it's for the new resident, the third-year resident that shows up like, I'm just going to do this block, and they don't understand the downstream effects. They don't think about the foot drop with transgluteal sciatic nerve blocks. They don't think about X, Y, and Z. So that codification allows them to like look at our protocol and be like, oh, that's what Arun's worried about, or everybody else might have vision. You understand the point? So I think it's actually a better trained tool for my internal department than it is for orthopedics or for anesthesia.
Definitely.
Yeah, so this is Trent from Hartford. I agree with Arun. The way our protocols at Hartford are written are somewhat educational for residents or faculty doing them. Our policy regarding admitted nerve blocks depends on the nerve block in question, but we have an agreement with our trauma service that the trauma service always offers the nerve block to the APS service first. It turns out that the APS service is usually they're pretty busy, and so rarely do they actually come down for the block. So even though it gets offered to them first, and that's what's written on our policy, more frequently than not, the ED is able to perform the block in question. So I think having that in our policy really helped us because it gave anesthesia right of first refusal, and it kind of gave them the opportunity to say, hey, if we're free, we can come do it. But in practice, hasn't really worked out that way.
Yeah, that's so important, Trent. And I think it's something that I think even when I built the protocol in our department, all my ultrasound people at the table were fighting me tooth and nail that we ask anesthesia to do the block because they're like, no, we've been doing this for 15 years. We're like the whole ego driven, but you're right? Like the minute you offer them the block and they don't do it, it's like the shitty nurse that's not going to get up. You just find the better nurse. So it's the same thing. They stopped even asking. They're going to stop asking anesthesia, and you're going to essentially be like, hi, anesthesia. Okay, no, thanks. Click, go do your block. But so I think that's exactly what you want to happen because then you show the utility and the importance of emergency medicine. And that's totally the right way of doing it.
Yeah, I think right now the way that we've got it set up is similar, Arun, where if anything comes up, they just on the floor after they're admitted, they just reach out to whoever has done the block or to me because I've just had all the meetings with everybody. For the discharge patients, we have pretty explicit instructions, and honestly, the big ones that we're really only discharging at this point are probably after rib fractures that have good enough pain control, and so they kind of know. I will say that the thing that's been very nice from our side has been starting this whole national registry thing, because that's also built in an extra layer of sort of 30 days down, just to make sure that they're not bouncing back, because we're explicitly doing sort of the chart review now to look for anything that may not have gotten caught on those first 2 passes.
So I saw the thing that Rob just posted. That's a great idea. I mean, I think I've gotten hold of a few anesthesiologists around the country to send me their discharge instructions. I just got it yesterday, because I want to build a really nice set of discharge instructions, block based, so we all have them in a PDF. So you're like, because I think it has to be very, very specific. I think for me, it's like if you get a, I don't know, supraclavicular brachial plexus block for a distal radius, it should be in patient language, that your numbness is going to happen. Here's your pain medications, like, you know. And there's this guy, Alex Stone at the Brigham, who wrote this nice piece I can send out, talk about bounce back from blocks. And it's all about the fact that people don't take their pain medication up front, right? You block somebody, they go home, you're like, oh, and then the patient doesn't know that they should start ibuprofen even though they're blocked. And then when it comes back, the rebound pain is so bad that it's actually worse than the initial pain. So this whole theory of like how to reduce that and kind of suppress that. And so I think that if we, again, build this, right, really nice, just simple blocks, and you have to do all the esoterica blocks, it would be a real resource for ED. And again, all this stuff is all publishable, and it really moves the field forward, because you can just print it out. Here you go, sir. It's in English and Spanish, or whatever languages you want to, you know, let Google translate. So I think it's really, really valuable.
Yeah, for sure. I think that's, I'd like something like this that's just like plain and simple, that I like just watching, you know, especially with residents, the different consenting processes, it's like all over the place. And I think that we need to standardize that a little bit. That's probably my biggest concern with our shop.
Yeah, Trent pointed out, yeah, I would love, trust me, we would, this is more of an idea. So if you want to get involved in this, I think it would be great. I mean, this would be, could you imagine how useful this would be for everybody? Like if we built standard discharge instructions for ED blocks and just pick 2 of them, 3 of them, like simple, yes. Again, publishable, downloadable. I mean, like this is the stuff where medicine has to get to, right? Rather than this very siloed kind of randomness that we do, because I'm sure everybody does it differently.
Hey, Arun, this is Shrikar. Quick question. Sorry. Do you use any template in the EMR to document the different components of the policy, like pre-block neuro exam, post-block neuro exam, that you actually have discussed with ortho resident who agreed, or whatever, you know, things like that? Whatever you listed in the policy, do you document using a template or something like that in the EMR?
So we have an EMR template, Shrikar, that documents a block, and it's a pretty blunt instrument. So it isn't very detailed. Like we just say a normal neurological exam is performed, yes or no, and it's normal. So it's a more of a blunt instrument. I agree that it'd be nice to have it even more granular. But the problem with that is that for my residents to put in, you know, I try to make the templates simple so they're not too cumbersome. And the old templates were, I mean, epic long. And so we've tried to make it simple, but that's a great idea. I think on the back end, in my opinion, it should be the discharge instructions that have that granular data, because then the patient can read it, you can circle it, like, this is what I really want you to worry about. But you mean the front end. You mean I document that the person doesn't have a foot drop before I do a transgluteal sciatic nerve block. Is that what you're saying?
Yeah, agree. And also, even though the policy is written, some of the residents seem to be not aware, the ortho residents. So it's nice to kind of go ahead and document that we discussed with somebody and whatnot. So that's what I was talking about.
We have a checkoff box that we added a consult, you know, anesthesia consultants were consulted, but that's it. It's not as granular as it could be, and it's purposely because of ease of use.
No, I think even if it is very short, like you're saying, I think that serves the purpose. Yeah.
Do you guys believe in standardized language of consent forms, where, like, for a specific, like a transgluteal block, like one of the possible complications would be foot drop? Do you guys believe in standardized consent forms for each particular type of block? Would that be kind of like, it would be a companion to discharge instructions sort of thing?
Another great idea. And when I asked the anesthesiologist if they don't have that, and even when again, you probably saw Alex talk about this at ASRA, he talked about the fact that he feels that instructions in acutely injured patients or risk benefits in a, you know, like consenting an acutely injured patient is probably not very efficacious and probably biased in so many ways. So I agree. It'd be great if for every block I had the clear instructions. It just, that's a lot of work. If somebody wants to pull that through, I think it's a great idea. And I think, Joe, I want you to chime in on this because we were kind of talking about something that you've just put into motion.
There we go. Sorry. Yeah. I'm just. Yep. Yeah. So we one of the things that we do now is we actually have a standardized e-consent that I wrote the standard like nerve block in general language for, but the way that we built it was that it allows us to add specific language based on the block, so that we could something like the transgluteal sciatic nerve block in addition to the basic stuff. You could also add foot drop in other language. I was trying to think of the other thing. Oh, I was wondering about I just posted something on the chat about whether or not using something like the POCUS, like I think there was a collaborative nerve block app, and if we could do like a back end for discharge instructions, it's basically the exact same setup that then would allow us to like easily print standardized discharge instructions as well.
Yeah, I do think so. I think it just, they're asking on the front end. So before you consent somebody to a distal radius fracture, like it has distal radius fracture, doing a supraclavicular block, are you going to, you know, go over the clear downstream effects? Like this could cause frank nerve paralysis, make the breathing a little difficult. And I'm sure we all say it, but it would be nice to have that we could deliver. So I think it would be a compendium. It'd be a companion from the front end to consent with a back end discharge. I think that'd be
For
great.
sure.
It's a little bit of work for people. I think if somebody wants to put that together, I think we could all help out with getting that off the ground.
Yeah,
That's why I
that'd be
really
great.
like
I gotta